Hello, welcome to Mito Canada's webinar, Managing Mito, Current Gaps in Care and Hope for Future Therapies. My name is Rashid Clark, and I'll be moderating today's webinar. I'm joined today by Dr. Anil Khan, who will be delivering today's presentation. And first of all, to everyone, thank you for your patience in joining us. Dr. Khan was dealing with a patient, and that's why he was running a little bit late. I think something that we can all appreciate is part of the nature of being a doctor. And Dr. Khan, thank you again so much for your time here today. Before we get into today's presentation, just a little bit more about Mito Canada. Mito Canada is energizing lives. We support those living with mitochondrial disease with information, support, and opportunities to inspire, empower, and connect, like we're doing here today. We develop education and awareness programs like the one today, and we enhance the understanding of Mito and improve quality of life. We advocate for those living with or at risk of developing mitochondrial disease, and we fund research that's patient-focused and transformational. And we dedicate every day to creating a world where all lives are powered by healthy mitochondria. Please remember that this event has been made here for you. So while you may be on mute, you are encouraged to ask questions. Any questions that you may have over the course of the webinar, please drop them into the chat panel, not into the Q&A, and we'll get to as many questions as we can before we wrap up today. And we're here today to learn. So during today's session, Dr. Khan will explain what mitochondria are, why they matter, how mitochondria disorders are diagnosed, and how Mito is treated. And he'll also look at current gaps in care and explore some of the therapies that may be available in the future. So a little introduction on Dr. Anil Khan, who is the president of Magic Clinic and CEO of Discovery DNA. He's also a researcher, with his main research interest being the investigation of novel methods for the treatment of childhood onset genetic diseases. And as a pediatrician, medical geneticist, and metabolic diseases specialist, his clinical research has primarily included subjects with inborn errors of metabolism. Dr. Khan is currently a principal investigator in multiple studies investigating the role of novel therapies like gene therapy and next-generation sequencing for mitochondrial disorders, bone imaging in metabolic diseases, metabolic cardiomyopathies, and rare disease registries. He trained in medical genetics at the Hospital for Sick Children in Toronto, working there for a brief period in clinical and metabolic genetics, then at the University Health Network, McMaster University, Alberta Health Services, and he now has his community practice in metabolic and clinical genetics in Calgary, Alberta, where he joins us from today. So Dr. Khan, I will turn things over to you. The slides are in your control, but again, if you need me to advance anything, just let me know, and the show is yours.
Thank you very much, Rashid. Can we do a sound check? Are you able to hear me?
Yes, I can. I think we're in good shape.
Oh, excellent. And thank you, everybody. Thank you to Mito Canada for this opportunity to talk. I apologize for being late. But as you all know, it's better to answer a few extra questions at the end of a clinic visit rather than cut it short. So these are my disclosures in terms of research grants, and I do have a patent for doing mitochondrial testing, which is relevant to the topic today. So that's a disclosure we need to make. Some of the other things have been mentioned before, so we can advance from this slide. I think you might have to do that because none of my controls seem to work. Okay, and so what we'll cover basically are what are mitochondria and why they matter, how mitochondrial disorders are diagnosed, treated, current gaps in care, and the hope for future therapies. Next slide, please. Now, mitochondria provide the energy we need to survive. You cannot live without them. They are the main reason we breathe air and need oxygen. It's a very basic question, but it's a question I often ask on rounds is why do we breathe oxygen? It's for the mitochondria. So energy production is one of their major roles, but they actually have dozens of other roles. And it's absolutely essential that mitochondria are healthy for our bodies to be healthy. We have trillions of mitochondria in our body. There's many hundreds in some cases in every cell. And almost every cell type in the body has mitochondria, with some exceptions, like mature red blood cells don't have mitochondria. But the origin of those cells still will be cells that had mitochondria in them. And some of the organs that use a lot of energy, like brain, heart, and muscles, are really reliant on mitochondrial energy production. So there's a lot of energy component to why we need mitochondria, but again, they serve many other functions as well. That's something to keep in mind. Next slide, please. So what are mitochondrial disorders? And you'll be surprised, but we still struggle with the definition. Now, understanding that mitochondria are tiny structures within our bodies and we need them to make energy, then one can classify mitochondrial disorders as disorders where there's insufficient energy production. And that certainly seems to be the case in terms of our usual understanding. But we're understanding that when mitochondria aren't working properly, there are a large number of other disease types that can exist. But this has been the classical way that it's been described. We recently put out a paper with colleagues describing how certain intellectual disorders and what we call skeletal disorders seems to be a delay in advancing the slide. Next slide, please. Okay. So when we look at mitochondrial disorders, we have to consider that you can have an issue with how mitochondria function, and that can lead to certain symptoms of mitochondrial disease. But you can also have an issue with how many mitochondria you have. There may not be sufficient numbers of mitochondria. So when you're looking to diagnose a mitochondrial disease, you do have to look at both function and or the amount that you have. The amount that you have is, some of it comes down to things that we call mitochondrial depletion syndromes or words of that nature. But it's not just a matter of what's there. So for example, you can, let's say you're trying to make a candy cane and you have the same amount of sugar and the same amount of red candy in there, but it's not in the form of a stripe. And you might not call it a candy cane. So both the assembly and the amount of a substance is important. Next slide, please. So what are some of the symptoms? We talk about energy production. If you think about it, are you going to use energy? Well, you use energy to move around. So you can have muscle pain, muscle weakness. Sometimes it can get really bad and the muscle can get very sick. That's a situation called rhabdomyolysis, where the muscle gets very sick and it gets inflamed, and things like your CK level go up. You can have exercise intolerance. Your heart could be weak. You may not be able to defend your blood sugar. You have low blood sugar. Or you can have problems with your liver, elevated liver enzymes, your nerves, retinopathy. One of the things that's not here, for example, is brain function. So you may not be able to think clearly. You may have seizures. And the brain uses about a quarter of the energy in the body. So a lot of mitochondrial disorders will have a neurologic component. Next slide, please. Now, just some terms, when we go to understand how mitochondrial diseases affect us, we have to look at it from the modern perspective. So in general, we think of mitochondrial diseases where the origin of the disease starts from your genetics. So your DNA, which contains the instructions on how mitochondria can function, there's some issue with the DNA that affects how mitochondria are formed or how they work. And that's usually the type of mitochondrial disease that people like me deal with, which are inherited diseases or genetic-based diseases. Now, your mitochondria can get sick. Let's say if you get into a car accident and there's not enough blood flow to the leg because of a fracture, those mitochondria can get sick for other reasons too. Those are secondary mitochondrial disorders. Most of what I talk about will be for genetic disorders where there's a genetic origin. And we have about 20,000 genes. So a change in one of the genes can lead to instructions that don't work properly in the mitochondria. And that's why we often look at slide, please. Okay. So types of mitochondrial disorders. So like I said, the primary mitochondrial disorders are the ones where our genes affect mitochondrial function. Now, the old term that was used was mutations. We don't use that term anymore. We use DNA variant, but it's just a segue into what that term is. And like I said, secondary changes are other factors other than our genetics that can affect mitochondrial function. Next slide, please. So why does one need a diagnosis? So, somebody might have done their research on mitochondrial disease and say, well, I have fatigue or I have brain fog or something's not working properly. And then you look at the process of getting a diagnosis and it looks like, well, this is going to take such a long time. Why do I need a diagnosis? It's because a lot of symptoms in people who have mitochondrial disease can overlap with other diseases. And when you're learning how to deal with those issues, it's important that you know what the issue is due to. Is it due to a mitochondrial disorder, or is it due to another gene where the approach to treatment will be different? So getting a diagnosis is important because it provides a description of what the cause might be. And then you can look at different treatments based on whether you diagnose somebody as having a mitochondrial disease or maybe some other type of neurologic disorder. Also, access to clinical trials these days will require that there is a genetic DNA diagnosis that is present. And one also can get some idea of what to expect in terms of healthcare changes over time by knowing what the exact answer is. Next slide, please. And there are certain steps your doctor might take to get a diagnosis. Of course, they're going to review your medical history, do a physical exam. They will measure certain things in terms of your strength and endurance, head circumference, eye function, so on. They may order certain tests. Not all of these are necessary in all cases, but depending on what the presentation is, it could be any combination of these tests listed here. Next slide, please. Now, in the modern era, a diagnosis will typically require having a DNA result that confirms the type of mitochondrial disease. Now, there's still some issues with getting access to that type of testing. And in many clinics, that's often the last step, and people may order the MRI first or the muscle biopsy first or do other things first. But at the end of the day, it often does coming down to getting a DNA test as a diagnosis. So now the approach in different clinics is going to be a little different. In my clinic, we actually start with the DNA testing first because we know if we're going to get a diagnosis, we need to know what the pattern is. Also, because there's an overlap with mitochondria with many other diseases, you might get another diagnosis that's not a mitochondrial disorder, in which case then you wouldn't do a muscle biopsy in some of those situations. And in some of those situations, you may not do an MRI, or you may decide to do different types of tests. Some functional study from the muscle or skin biopsy sample, so some tissue sample where we study how mitochondria work, or we look to see how mitochondria look in the tissue is often required. So that's why those biopsies are done. Or or we send the biopsy to different labs around the world to see how the mitochondria are working. So how they look, which will tell us whether they look sick or not, how they function, so enzyme studies or something called blue native page, and DNA testing. That's often a core element of finding out whether a diagnosis can be made. Next slide, please. And in terms of our genes, we actually have two basic sets of genes. So in the nucleus of the cell are the genes, the DNA we inherit from both parents. That number is about 20,000. And the best test right now, or sort of risk-benefit ratio, or best test, is what we call whole exome sequencing, which will scan the coding regions of all 20,000 genes to see if there is a DNA change there that causes mitochondrial disease. And this can be done off a cheek swab, which is non-invasive, which is one of the reasons we start with this test first, because compared to an MRI or a muscle biopsy, which is going to be invasive, and the anesthesia, especially in small children, can involve some risk, this test is our starting point in many of those situations. Now, mitochondria also have their own set of genes, a little over 30 genes, and they should be tested first too. And we do start with mitochondrial and nuclear gene testing together. But testing for mitochondrial genes is a bit finicky. And in many clinics, if they start with WES, sometimes the WES test will report mitochondrial genes, but it is actually not the best test for mitochondrial genes. Also, using a spit sample or a cheek swab is not the best way to test mitochondrial DNA. So the clinic needs to be aware that mitochondrial testing needs to be done. And you can start the testing in blood and urine, but the gold standard is tissue. And it's one of the reasons why at the end of the line, there may be a reason to do tissue. Now, for some mitochondrial diseases like MELAS, for example, which many of you may have heard about, blood testing is usually adequate to say whether MELAS is present or not. But for other types of mitochondrial diseases, particularly certain mitochondrial gene deletions that run in certain families, it is tissue which will be the ultimate test that will tell us whether the deletion is present. And the three techniques right now for tissue analysis that are really at the top of the line, and I know these are technical terms, are things like Southern blot, long-range PCR, and nanopore sequencing. So in those difficult cases where one is going down a road to see whether there is a mitochondrial disease, then in those situations, we are doing muscle biopsy and we're employing one of these three techniques to see if we can find out if there's a mitochondrial disease. And in our data, we get about a 30% higher yield from mitochondrial mutations when we use those techniques, but they're not available in every province or even in some of the labs that the provinces contract to do the testing. So it's just something to keep in mind that there's always a few stones left to turn over when trying to get to a mitochondrial diagnosis. Next slide, please. Now, when you're testing through a lab, and I know because I see many patients who get frustrated with the wait time to see a specialist and to have the testing, and they may be using labs where they do a internet search and the lab says they offer the testing. If you're doing testing for mitochondrial disease, that lab needs to be familiar with how to diagnose mitochondrial disease. If this is not something that they do, then they could easily miss a diagnosis. So it has to be something that they actually do on a regular basis. The lab should also be accredited by an external body. And what accreditation means is some agency has inspected the lab, physical inspection, and also they get test sequences, which they need to get right to make sure they are producing a result that is usable by patients. So most of these accreditations in Canada are done by the provincial bodies, the colleges. So in Alberta, for example, it's the College of Physicians and Surgeons of Alberta. So if you are considering a test done in a lab to look for a diagnosis, look to see what the accreditation is. Some of the hospital labs might have their own accreditation internally. If things are sent to other countries like the United States, their accreditation bodies are different. But the lab should be accredited in the region that it's in to make sure they're producing an accurate result and that they're making a diagnosis of mitochondrial disease, because some people are given a false understanding of what the diagnosis is. And that leads to a lot of stress and a lot of extra work to try to clean that up. Sorry, my throat's a little acting up a little bit today. So even commercial labs can have limitations. And one of the things to remember is the large deletions in the mitochondrial DNA fraction are not amenable to testing using a whole exome sequencing, or in some cases, a whole genome sequencing platform. There needs to be specific mitochondrial DNA testing, especially when the deletions are larger than 5,000 base pairs. And that's a particular mitochondrial problem, and that's why somebody has to be familiar with the limitations of those testing. Next slide, please. So muscle biopsy, where we get a piece of muscle tissue, which is usually the size of a pea and one or two pieces like that, is an invasive test. And there are a few ways to get this. One is through what's called an open biopsy, where a cut is made in the muscle and a surgeon goes in and removes a piece of muscle. There's also what we call a needle biopsy, and I'm only aware of two people. One, the person who trained me, Dr. Tarnopolsky, and myself, who are using needle biopsies on a regular basis to get muscle. But you have to go in there and you have to get the muscle tissue. Now, currently, like I said, DNA testing in our clinic is actually the first step. So I will usually get an exome and mitochondrial testing first, and then do muscle biopsy, often as a last step. And we have a study, which we'll talk a little bit about, that showed that that's a reasonable way to do it and reduces the number of biopsies you have to do and the anesthetic risk to patients. Also, remember I said for mitochondrial DNA, tissue DNA is the gold standard. So if I get a diagnosis where I don't need the biopsy, then I don't do the biopsy. But if I do need the biopsy, then I ensure that mitochondrial DNA testing is done off of that biopsy. And sorry for the typo, biopsy is an option instead of a muscle biopsy when the concern has to do with liver disease. And remember that when it comes to some of these mitochondrial disorders, the tissue biopsy is the gold standard, because you can look at the mitochondria and the tissue under a microscope. You can run enzyme studies and other types of studies on it, and you can extract DNA. So at the end of the day, that becomes the gold standard. And there's many cases where we've tried to solve the case without doing an invasive test, but it was the invasive test that ended up making the diagnosis. Next slide, please. So these are just some slides and some patients. On the left is a patient that was referred to me for muscle weakness. And you can see a blue coloration, which is a stain of the slide. And there's another sort of purplish stain of those two cells in the middle. One, and they're looking at it from different angles. But if you look at the middle cell where there's a clear blue area and then red to the side, that's a cross section of that cell. And that staining is called ragged red fibers on what we call a Gomori trichrome stain. So when we see a lot of those under the microscope, that is a pattern of a mitochondrial disease. And on the right, then you see electron microscopy. So on every tissue that we test here, we always do electron microscopy. And you can see in the electron microscopy, you see these dark bands. Those are the mitochondria. And the mitochondria typically don't have bands that dark or stacked. So that's a particular pattern called a paracrystalline inclusion, and it identifies mitochondria that don't appear well. And so the electron microscopy is a much higher resolution than the slide on the left, which is a general microscope slide, where you cannot see individual mitochondria, but you can see from the ragged red fibers that there's clustering of those mitochondria. And then when you do electron microscopy, you can see the individual mitochondria, and you can see those structures. So with this patient, even though we did genetic testing on the patient had a MELAS 3243 A to G DNA variant, you can tell in the muscle biopsy that this is a mitochondrial disease case. Next slide, please. This is an example of some functional studies, and I'll go through this because it can be a little complex. On the left is a technique we call Southern blot. So this is a technique we do in Alberta. It is done off of muscle biopsy. You can do it off other tissues, but there's no point in doing it off something that is not the reference standard. If you're going to do a 7 blot, you should really be doing it off muscle. And you can see on the left is just a reference ladder showing many different bands as you go from top to bottom. And those are different fragments, different DNA fragments. So if you had a problem with mitochondrial DNA, then you would see fragments lower on to the bottom part of the ladder. And so we have a patient sample there shown in red arrows where you can see it has a very similar pattern where the bands go up to this very bright band at the top, but then you see these fainter bands as you go to the bottom, and that's because the DNA has been damaged and you see different fragments. So there could be a deletion, a missing piece in that DNA or other issues, and that's a way on Southern blot to see that things are damaged. In the middle, you see a slide that shows what's called blue native page, and the page is an acronym for polyacrylamide gel electrophoresis. And this sample was sent to Dr. Johan van Hove's lab, which is a lab we typically use for this test from Alberta cases, and it's in Colorado. And what I want to show you there is if you look at the middle, you see CONT, which means control, in the dark image. And then to the right of CONT, you will see LM. And then you see the Roman numeral for 5, which is a V. And you see at the top, you have 2 bands in both the control and LM. But in the LM slide, if you move to the bottom, you see another band. And that's because the mitochondrial DNA has been split. And that split produces 2 fragments. So if I gave you 1 candy cane and then you have 1 piece, if I break the candy cane in 2, you're going to have 2 pieces. And that break tells me there's something wrong. And so that's a doublet in complex 5, and it tells us something's going on. And on the right, what I've shown is where the break is. So this patient had a complete deletion between those 2 red bars. And it was different than the current SERA deletion, which is a common one. So they had a unique mitochondrial deletion, which if you did not do a muscle biopsy, you did not send blue native page, and you did not extract mitochondrial DNA, it would have been completely missed. None of those other tests showed me this. So this patient has a mitochondrial deletion syndrome. So that's an example of these other tests that are used on top of a muscle biopsy, but all of these tests are done from muscle tissue to prove what exists there. And if you looked at the tests, including MRI, blood lactate, or any of those other tests before muscle biopsy, you could not give a diagnosis. It's only after the muscle biopsy that all these tests are run and we can make a diagnosis. So that's highlights the importance of tissue biopsy in many of these cases. Next slide, please. Now, brain imaging is also used. Now, in children, the yield on a muscle biopsy is a little low because they often have these nuclear mutations. And the nuclear mutations are determined on exome sequencing. And sometimes you can see a pattern in MRI. But if the MRI is normal in a child, then the yield from a tissue biopsy is actually not as good as the tissue from exome as exome sequencing. So that modifies how you approach that. In adults, the largest number of patients you see with mitochondrial disease have what's called CPEO, which is chronic progressive external ophthalmoplegia, where it's very difficult for them to move their eyes in the usual pattern. And oftentimes they have a lag of the eyelid, something called ptosis. And there, more of those cases are due to deletions than in children. The muscle biopsy actually has a high yield. And that's important because in children, you may need to use anesthesia to do the muscle biopsy. So the moderate approach is generally to use exome sequencing and other non-invasive techniques first and save the muscle biopsy until you need it later. In adults, it actually may be, in some cases, what you start with if you can't get the answer from non-invasive means. This is an MRI of a patient who had a neurological issue and came into hospital. And when they called me to see the case, they thought this patient had a stroke, and it turned out it wasn't the standard type of stroke. It actually was a metabolic stroke. And on that MRI on the right side, you could see an increased whiteness along the brain. Sorry, the pointer I couldn't get to work, but I think you should be able to see it there. And this was a very typical pattern for MELAS. And when we did the DNA test, we found this was MELAS. So that's an approach there where you use whatever clues are present and then use a DNA test to confirm what you had. And in this particular case, the MELAS test was done on blood. We had the MRI, we had the clinical history, so we didn't need to go and do a muscle biopsy. Next slide, please. So we published a study called MitoFind, which is the largest Canadian series. We had 390 patients that had gone through this study, where we used a combination of exome sequencing and muscle biopsy to determine what the best approach to diagnosis was. And our conclusion from the study was to start with non-invasive testing, which is exome and mitochondrial genome sequencing, and go to a muscle biopsy only if you don't get an answer. Next slide, please. So these genetic tests, though, they don't take a long time to do. We can do an exome and mitochondrial sequencing within days. So if you came in on a Monday, there are many situations where by Friday we have the test done. But getting access to that is very difficult. The first part may be getting access to a physician who understands that that's the route to do the testing. And then through the system, it may be very difficult to get access to that type of testing in many cases. But getting a genetic diagnosis can help identify a gene, and it doesn't in all cases. That can help understand what the recurrence risk is in a family and allow people to make decisions about the treatment and the prognosis and what to do. And it starts what we call the mechanistic journey, which is in many cases, the disease may be quite unique or rare, and trying to understand how it's causing the symptoms in a person, which can take a while. Next slide, please. So the wait is often the longest part, wait to see a specialist. And then to get non-invasive testing, some clinics don't do the exome and mitochondrial DNA sequencing first. They may start with a whole number of other tests. Muscle biopsy can be difficult and require referral to a surgical service. And there can be differences in provinces in terms of what testing can be accessed. And it's not always easy to cross over to another province and get the testing done, which is unfortunate, because you might think it's a universal system, but it's not universal in that sense. Next slide, please. So if we say there's a diagnosis of the mitochondrial disease, then the issue is there's a problem with how the mitochondria are working in a major way. So this means that often a DNA change has been identified. There's a change in how mitochondria function based on biopsy or biochemical testing or functional testing. But it's not really a diagnosis if you only have a suspicion or symptoms or family history. When you're in that situation, you often do need more testing in order to get to a complete diagnosis. Next slide, please. So we can talk about differences in provincial screening, but I think there's a time I'll skip through this slide and see if it pops up in the question and answer. But there is no real newborn screening for mitochondrial disease in Canada. So living with mitochondrial disease, next slide, please. So oftentimes many different doctors are involved, healthcare professionals in the management of a patient with metabolic disease. You can have dietitians, geneticists, metabolic specialists, cardiologists. So there will be many physicians in many cases trying to coordinate care to improve outcomes. Next slide, please. No, we don't have a cure for any type of mitochondrial disease, unfortunately. But that doesn't mean there's nothing that can't be done. Often the treatment plan is unique for every individual. One of the goals is to help improve symptoms and quality of life. And there may be special things employed to help with nutrition or eating or communication. Illness management is very important, because if you get sick from mitochondrial disease and it's not managed a certain way, it can be a big setback. Or if you have to fast for a procedure, like you're having a knee operation and you don't have the right fluids, that can be a setback too. So we want to make sure that best practices are used to avoid any setbacks and try to improve outcomes. Next slide, please. There are benefits to exercise if that's something that you can do. So if you have CPEO and muscle weakness on top of that, then exercise is a good thing. If you are a 3-day-old infant in the ICU with Lee's disease, well, you're not really exercising. So we have to keep in mind that there's a context for where some of these are used, but in general, it's one of the few ways to improve mitochondrial function and mitochondrial quantity is to do exercise. A combination of resistance training and aerobic exercise is often the best approach. Next slide, please. We'll skip this slide because I briefly mentioned the resistance training just for the sake of time. Oftentimes, people are on nutritional supplements. There is not a heck of a lot of proof that these supplements cause any major change. I do offer it to all patients. A significant number of patients will come off their supplements and we see no effect when they went on or when they went off. But this is a partial list of the supplements that are used. If you went through and chose every supplement available, you'd be on 20 or 30 of them. So that can't be the right approach either. It is generally observed, though, that most people are on, more than one supplement. Next slide, please. And I talked about the diagnostic test, so we'll skip this one. We'll try to cover a few things because I want to leave some time for questions. And we'll skip this one too. Okay, we'll go to questions and maybe I can incorporate some of the treatment stuff. Most of the treatments right now, there are some new clinical trials coming down the pipes to do specific treatments in mitochondrial disease. If it's a nuclear gene, the approach is different. That may require a gene therapy. If it's a mitochondrial gene, that might require what's called mitochondrial replacement. So a lot of the new therapies are mainly through clinical trials, but the general principles of nutrition management, illness management, and preparation for times when there's fasting are one of the key ways to try to keep people healthy. So with that, let's go to some questions. So we have some time for questions, and I see there's a few in the chat already. I wonder, yeah, I could give control back to you to make sure everything's okay before we go on to questions.
Yeah, and I think I'll just read out the questions unless you want to pick any that have come through. And again, for folks who are watching, you can enter your questions into the chat panel, and we'll get to as many as we can today. First one that came in kind of earlier on in the webinar, how can you have an abundance of mitochondria?
Okay, so in each cell, let's say a cell is healthiest with 400 mitochondria in it. And all of a sudden, you have damage to the DNA and the mitochondria can't reproduce themselves effectively and they die off. Now, instead of 400 mitochondria, the cell only has 500 working mitochondria. It's not going to work as well. So you can have changes in the amount of mitochondria that affect function. Sometimes when the cells are struggling, we see they're trying to make more mitochondria to overcome it. And those mitochondria may not be healthy mitochondria, but might be a clue that we see. So it's just like if you had dinner and you had a plate of rice, there's a certain amount of rice that's going to make you full. And if you have less than that, you will not feel full. And if you're a cell and you're looking at energy production and you don't have the right abundance, it doesn't matter that each rice grain itself is normal. You just don't have enough of it. So I hope that explains somewhat of what that is.
And another question, just to talk about skin biopsies and the utility of them. Like what do you see as the real value in skin biopsies?
So skin biopsies are used when a muscle biopsy can't be performed because it is possible that you might get an answer from a skin biopsy. Now, I want you to think about what your muscle does during the day and what your skin does during the day, because the muscle is more active. So trying to use the skin only, in some cases, you may get what are called negative results. Having said that, for some technique mentioned, there have been techniques published where the skin biopsy seems almost as good as a muscle biopsy when it comes to detecting those protein differences, those split bands. So, and a skin biopsy can be done using local freezing without general anesthesia. I've never used general anesthesia to do a skin biopsy in any person. I've done hundreds of them. So it may be one way if a muscle biopsy is too difficult to do to see if you can get an answer through a skin biopsy. If the road is leading you down a path to find an answer that a skin biopsy will produce. So an example of that is, if you're hungry and you're looking for pizza, and you go to a Thai food restaurant, you're not usually going to find a pizza there, right? So if you're looking for mitochondrial disease, you need to know that the skin biopsy, based on your history and physical, is going to give you an answer that it can produce. You don't just order one and expect it to answer all questions.
And just a note to everyone watching, in the event that you can't enter anything into the chat bar, please feel free to use the Q&A panel, because we did have a few questions come in through that one as well. Another couple of questions to get to before we wrap up close to the top of the hour. For Dr. Connor, what do you think is the most promising advancement right now that will give patients more hope in living with Mito?
So if I had to pick one, it would be mitochondrial replacement, where healthy mitochondria are put into the body and they dilute the number of sick mitochondria. Why? Because you could potentially use that for both mitochondrial DNA diseases and in some cases even nuclear ones, because a lot of the nuclear diseases work by causing the mitochondria to be sick. Now, if you wanted to change the nuclear gene, that would be through gene therapy, so that's another application out there. But most of the things right now are mitochondrial replacement or small molecule drugs or things of that nature that seem to be on the pipeline.
In terms of preventing disease, what options right now are there to reduce the risk of someone developing Mito?
Well, because these are genetically based, you don't really have an option there, because once you're born with whatever you have. So there are some reproductive technologies. I won't go into those in detail. They're quite technical and specific. But in general, stay healthy diet, exercise if you can, avoid certain stressors, avoid prolonged fasting, have enough energy in your system. Those are the general ways of preventing your body from getting worse if you have a mitochondrial disease.
And as we get to closing, just being aware of time again, any more questions anyone watching may have, feel free to drop them into the Q&A panel.
A couple in the chat, which I'll try to get to really quickly. One is, will the muscle biopsy only show Mito disease in the actual muscle biopsies or throughout the body? Most of the time, the muscle is an adequate sample for what's happening in the rest of the body, but not all the time. So in those situations, you might still do a muscle biopsy because it's one of the easiest things to get to. It's easier going, but you can't do the same things off the heart that you can do with muscle, right? Because I can take a big chunk of muscle, like tip of my finger, but you can't do that to the heart. You can't run blue native page and enzymes off. Well, you technically could, but you'd have to take a bigger chunk of the heart than usually what you get at a heart biopsy. So a liver biopsy is the other alternative if it's predominantly a liver issue. So the physician needs to know what tissue is the best tissue to go after. But it's usually rare to have such specificity that there's only one particular tissue that's only showing the problem. So oftentimes the muscle can still provide a clue to what's happening in the rest of the biopsy. Okay, other questions? Yeah, go ahead.
Another couple of questions in the Q&A panel. If you could explain what the WES or WES is and the DNA test.
Yeah, so as I showed in the slide, a WES stands for whole exome sequencing. It's sequencing the coding regions of the 20,000 genes in the nucleus. Those genes are different than the ones in the mitochondria, and the technology is slightly different to look at
them. One more question here.
I know some of these, a short answer, that's why it will take 20, 30 minutes in clinic to explain them, which we don't have today. So I'll just try to give you the most briefest form of the answer.
Makes sense. And we're trying to get to, as many questions as we can today. And maybe one last one for today. Someone, if you've been diagnosed for Mito, not known for stroke-like episodes, but you experience them, should you consider a muscle biopsy as well?
You may not have to. Now, in the mitochondrial world, we tend to lump and cluster things together, and it doesn't always work that way. So the body did not read the textbook. It's the other way around. So you can have stroke-like episodes with many different forms of mitochondrial disease, not just MELAS. In fact, MELAS, mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes, few of my patients have all those things. But we used to call it the MELAS gene, but we don't anymore. It's called the MTTL1 gene. So if you look at my letters, I don't call it MELAS. Why? Why would you call it MELAS unless they had stroke-like episodes? But you can have Kern-Serre syndrome have stroke-like episodes. You can have mitochondrial deletion syndromes have stroke-like episodes. So the physician looking after you should provide a broader scope of what the clinical features are rather than old-fashioned names which don't really apply to a lot of the genes.
Great. Dr. Khan, thank you so much for your time today. And again, thank you to everyone for joining us for the webinar today. And on behalf of Mito Canada, Dr. Khan, again, thank you for sharing your time, your insights, and your expertise with us. And again, to all of you for joining us, thank you. Hope you enjoyed our presentation today, Managing Mito, Current Gaps in Care and Hope for Future Therapies. This session has been recorded. It'll be up on the Mito Canada website early next week at Mito. While you're on the mitocanada.org, hope you'll have a chance to look around the rest of the website. We have lots of content coming out all the time, so it's a great way to stay informed on what's happening in the Mito community. And as we wrap up, I hope you'll have a chance to finish our post-webinar survey. Just to let us know what you thought about today's presentation and what you'd like to see for future presentations, because of course we do all of this for you. So please let us know the areas that you're most interested in, and we hope to have more presentations and webinars for you in the future. So Dr. Khan, once again, thank you for sharing your time and your expertise with us, for answering the questions. And to everyone watching today, thank you for spending some time with us. All the best to you, all the best in health, and hope to see you again soon. Take care.